A 50-year-old gentleman came to the OPD with the complaint of the prominence of the both eyes and complaints of diminution of the vision in both eyes since 1.5 years. History of the present illness, he complains of the prominence of the both eyes since 1.5 years, which is gradually in onset and worsening in nature, and complaints of diminution of vision in both eyes since 1.5 years, gradually in onset and worsening in nature, and is associated with the redness, watering of eyes, no complaint of diplopia, no complaint of eye pain with eye movements, and no symptoms of thyroid dysfunction, and no history of diurnal variation. Past history, he is a known case of hypothyroidism since 1.5 years, and he is on treatment on Tyronom 50 micrograms. Currently, his thyroid profile is normal, and he is known case of thyroid eye disease since 1.5 years. And at the time of the presentation, at the initial visit, he is tested anti-thyroid peroxidase antibodies, anti-thyroglobulin antibodies, and anti-TSH antibodies positive. And within 1.5 years, he received multiple doses of the IVMP. Cumulative IVMP dose he received is 6.75 milligrams, as he had multiple episodes of the decrease in vision due to the dysthyroid optic neuropathy, which was medically treated and surgical decompression was not done. During this treatment, he developed right eye exposure keratopathy with microbial keratitis and corneal thinning, for which he underwent right eye tarsorrhaphy. And he was also treated with oral steroids, methotrexate, and 2 injections of rituximab, 1000 milligram. And is not a known case of diabetes or hypertension.
Okay, Aishwarya, just go back to the previous slide. So you said that it was a gradual progressive decrease in vision. You sure? Then why has the patient got injection 1 gram and then exposure keratopathy with tarsorrhaphy? Do you think it would be gradual progressive? So, okay, what are the causes of decrease in vision in a case of thyroid eye disease?
Exposure keratopathy, compression of the globe causing astigmatism, dysthyroid optic neuropathy.
So, sight-threatening complications are basically only two things. One is DON, which is dysthyroid optic neuropathy, and exposure keratopathy. So, that would be a sudden decrease in vision. So, this history, whatever she said, it's a good thing you told what all was received by the patient, but that sudden drop in vision is an important history. Okay, so what have they treated with? As you can see there, they have given 1 gram for 3 days. That is the treatment of.
DON.
Okay, then for dysthyroid optic neuropathy, we give 1 gram for 3 days. Following which, what should we do? For all patients, what is the treatment of dysthyroid optic neuropathy?
1 gram per day for 3 days. Then IVMP pulse 500 mg per week for 6 weeks with or without radiotherapy. And then
Okay,
we
so that is
reevaluate.
if the patient improves in vision. Okay, so in this case, what happened was after 3 days of 1 gram IVMP, patient did not have any improvement in vision. So it was a case of chronic dysthyroid optic neuropathy, acute on chronic. So ideally, if it doesn't improve after 3 days, you check color vision for the patient, and if it does not improve, then we have to go in for what? So
Surgical decompression.
surgical decompression. So that is important. So what is the other cause of the diminution of vision in thyroid? You said
Exposure.
exposure keratopathy. So what's the treatment for that? All patients you do tarsorrhaphy.
Lubrication.
Ma'am, lubricant eye drops we start with.
Yeah, so many a times when they have lot of inflammation, if there's not much of exposure, just giving IVMP itself will decrease the inflammation and the lag of thymus will reduce. But tarsorrhaphy is a sight-saving procedure. A simple tarsorrhaphy can save vision actually. So it should be done as an emergency if there is an epithelial defect or an exposure-related ulcer, melt with the back of a cornea if it is required. Many times patients do present with that. Can you go back to the history? So history wise, prominence for 1 year, it was gradual and it's worsening. Okay. So what are the associated negative history that you will ask somebody else say, and why the negative history? So patient presented with proptosis, prominence of eye, and diminution of vision. What other history will you ask?
Any history of fever, but that's an idiopathic orbital inflammation.
Okay.
Ma'am, because it's bilateral,
Okay.
axial.
For 1 year, fever history.
Ma'am, we can ask for the progression. Is it how fast is it? Then we can ask
That
for
she's already, yeah.
asymmetric like in which eye did it start first, any systemic problems we have, and also associated
What
double
systemic
vision,
problem?
any previous tumors in the body or any radiation they've received.
Okay,
Proptosis can
first
be,
negative history of the eye, right?
yeah. So double vision diplopia.
So what
You
are
have to
these
ask
redness, watering, and all signify? Why is that important?
exposure,
For the activity of this disease. So what is the
hmm,
other important negative history which comes in the activity score?
strabismus and diplopia.
Diurnal variation and pain on extraocular movements. Those
Hmm.
two history you have to ask, that will change the scoring of the patient. Okay, and double vision, again, that is also important. If it is double vision, specifically you should ask in primary gaze or in down gaze. Okay.
Personal history, he is non-smoker and non-alcoholic. Family history, there is no history of thyroid disease in the family members and no similar history of thyroid eye disease in family. On examination, head posture is normal. There is no facial asymmetry. Hirschberg is ortho, and best corrected visual acuity in both eyes is 6 by 36 and N36. Color vision is both eyes is 1 by 21, and there is RAPD in the right eye. In the left eye is regular reacting to light. On extraocular movements, as we can see, there is decrease in the eye movements in the abduction and adduction, and also mild restriction in the elevation. On orbital examination, on Hertel's exophthalmometry, OD measures 27 mm and OS measures 26 mm. We can see the upper eyelid retraction, lateral flare, lid lag,
What is considered as proptosis? Beyond what millimeters?
21.
Okay. How else can you
And
grade the
asymmetry
proptosis?
between the both eyes is more than 2 mm.
And also at different times, if you see the
Increase
increase
in
in proptosis
proptosis.
by 2 millimeters or more.
And palpebraal fissure height of both eyes is 15 mm and MRD1 of both eyes is 7 mm. Superior scleral show is 1 mm in both eyes. Inferior scleral show is in 3 mm in both eyes. Lag of thalamus is present in both eyes, 3 mm in right eye and 4 mm in left eye. And RBR is raised in both eyes, and finger incision is possible in both eyes, and pulsations were absent in both eyes.
Only pulsations, anything else you have to tell? Especially in this case. Go back. What do you see in the eye? You can also see the conjunctiva. Only congestion, caruncular edema, then are the vessels okay? Yeah, they are looking like corkscrew vessels actually. So, what is your differential diagnosis? So, what is the examination finding which is important? Valsalva will be positive in which case?
AV fistula, AV shunts.
AV
No, no,
shunt.
no.
AV has arterial. Arterial will have pulsations. Venous only will have valsalva. That is a slow. It is a filling of the vessels, right? When there's an arterial communication, you will have pulsations. So what are the causes of pulsatile proptosis? So you should classify it as, yes, true pulsations and transmitted pulsations. True pulsations means there is artery involved in that. So what are the conditions? Yes, CCF and AV malformation. So can this patient have a CCF? Is it a differential diagnosis? It is a
Yes.
differential diagnosis. But what goes against a CCF in this case? No pulsations. That's only, I think, what other pulsation should you check further? On Goldman applanation tonometry, also you should check for pulsations if this pulsation is negative, and also you should check for a thrill and also auscultate and see. Okay. Then what goes against a CCF in this case? Just by looking at the picture.
Other features of thyroid,
What other feature?
lid retraction.
Yes, so lid retraction is there in this patient. So in a CCF patient will not have lid retraction because it's quite a pathognomic feature. What are the causes of lid retraction? Why does a patient have lid retractions in thyroid eye disease? Can you tell the causes?
Fibrosis of the levator palpebrae superior.
Okay, then 1, 2, 3, 4.
Mullers muscle contraction,
Okay, why?
increased sympathetic activity,
Yes, then that is the first one that you say. The second one is, which is the most common muscle which is involved in thyroid eye
inferior
disease?
rectus.
Yeah, so
superior rectus LPS
Overaction of the
complex.
superior rectus with the lid retraction because of that. Then fibrosis, and then because of the proptosis itself is one other thing that they say, but that is usually the last cause. Yeah. So then one more thing. What is lag of thalmus and what is lid lag?
Lid lag is upper eyelid unable to keep pace with the lower eyelid on downward gaze, and lag of thalamus is like incomplete closure of eyelid.
Good. So once the patient has lag of thalmus, how much is the lag of thalmus in this patient?
3 mm in right eye and 4 mm in left
So automatically the next thing is what should you write? What should you look for if there is lag of
eye.
thalmus?
Corneal exposure,
And
keratopathy.
bells. So when you say lag of thalmus, if the patient has lag of thalmus, the next thing you should say is
Bells.
bells and whether how much portion of the cornea is
Cornea is
exposed, because that is what is important. Okay. What are the causes of lid lag? No, other conditions where you get a lid lag. Yes, congenital ptosis. Why?
LPS.
Sorry, LPS and superior rectus.
Muscle is replaced by fatty and fibrotic tissue in congenital ptosis, the LPS
So
muscle.
fibrotic tissue is there. It will.
So,
What
no,
is it?
It keeps it pulled back rather than allowing it to droop.
Yeah, it's a stiff muscle basically. That's why. Anything else? What are the other causes? It's a dysgenetic muscle. This is what you should say. Dysgenetic muscle, and it's called. It's a stiff muscle. Okay, so it doesn't follow the globe. Okay, then what are the other causes?
Post trauma, post surgery,
Post trauma. Why will they have lid lag?
LPS disinsertion or anything.
LPS disinsertion.
Head
What you'll have?
prosthesis,
Ptosis, complete ptosis. That is an aponeurotic. So they'll have more drooping in down gaze.
gaze.
That is the opposite.
Yes.
Then
Contracture.
trauma, you
cases
said
of-
they can have. When there's a anterior lamellar shortening, then also they will have lag of thalmus lid. Then post surgery, what surgery?
Ling surgery.
Any ptosis surgery.
Any.
Okay. Yeah.
So, already discussed, anterior segment findings seen in this patient are the congestion, prominent episcleral vessels, caruncular conjunction, and there is no chemosis. Cornea in the right eye has healed keratitis, and in left eye there is corneal scar and inferior corneal thinning. Iris is normal in both eyes, and anterior chamber is VH4 grading, and it is quite in both eyes. Lens shows early lens changes in both eyes, and IOP is 13 in right eye and 14 in left eye. Gonioscopy is both eyes open angle. On posterior segment examination, vitreous is clear in both eyes and disc is moderate in size with mild temporal pallor in both eyes. Macula is normal and fundus is normal in both eyes. In this patient, clinical activity score is 5 and the visa inflammatory index is 6 out of 10, which denotes that the disease is active. And the investigations done in these patients are the
So how, what is your diagnosis till now? Anybody else? What's a clinical diagnosis? No. Okay. You guys listen to the case presentation. No, no, you're telling me diagnosis.
It looks like an active phase of thyroid eye disease.
What are the two phases in thyroid disease?
Active and quiescent.
Okay.
So that Rendel's curve will be there. So first will be active and then quiescent phase.
Fibrotic phase, yeah. So active thyroid disease then?
With corneal changes, corneal thinning in both the eyes, exposure keratopathy, and vision, chronic dysthyroid optic neuropathy.
Dysthyroid optic neuropathy, why? So what are the optic nerve function tests?
Vision, color vision, contrast,
Vision, color vision, then
contrast sensitivity,
next is pupil,
pupil,
then
VP, fields.
VP fields, contrast. So in this, what all did the patient have positive already?
Visual acuity, color, and
Color vision was how much?
1/21.
With
even
red
with
filter.
the red filter.
Yeah, so that is important. Then,
RAPD.
and there was disc pallor. I'm guessing the pallor was more in the right eye. Why was there pallor already? Some amount of pallor was there. Because it is an acute on chronic sort of a case. Can you have dysthyroid optic neuropathy in a quiet, like in the fibrotic phase? Or is it seen only in the active phase? And what's the treatment for that? So almost always, usually we see dysthyroid optic neuropathy in the active stage. Active stage means what? There is a inflammation, anterior or posterior, either clinically or radiologically. So there is two types of activity. One is clinical activity scoring, the other is radiological activity, wherein we see the muscles, right? So in the fibrotic stage, it's rare to see a optic nerve compression, but still it can happen. So in that case, you don't give IVMP because there's no inflammation, so there's no use giving IVMP for a dawn in a fibrotic phase. You have to do decompression directly. Okay. So what are the investigations that you'll advise now?
Thyroid profile, ma'am.
Okay, that will take 2 days to come. Yeah. Then this has thyroid optic neuropathy. So it's like a semi-emergency. Yeah, somebody said, yeah, Himani. MRI orbits, what all will you look for in that?
We'll look at the recti muscles
Okay, and the other
and if
muscles,
there's
yeah.
any compression of the optic nerve.
What would you look for in the recti muscles?
The thickening, whether there's tendon involvement or tendon sparing.
First of all, whether it is radiologically at ED. So features are tendon sparing, enlargement of the extraocular muscle, and what are the muscles which are involved first? You know the mnemonic. I am slow. Yeah. Okay. So that you have to see, and then how much is the enlargement and how much is the activity. Activity we see in the T2 weighted images if there is radiological activity. If it is hyper intense on T2, that means there is active. So what is this intensity compared in the imaging? Can you show that imaging of the you have no?
Yes, ma'am.
Yeah. So what's the first one?
Ma'am, it's a T2 weighted axial scan of orbit. Then we can see there is this enlargement of the medial rectus and the lateral rectus of the right eye.
Only medial rectus and lateral rectus?
Inferior rectus also, ma'am.
Yeah. Or more enlargement is the inferior and medial. Very typical, no?
Yes, ma'am.
Yeah. Then
There is a hyperintensity in the muscle which
in
suggests that there
T2.
is still
Yeah.
activity.
When did you say the muscle is enlarged beyond how many millimeters?
Ma'am, usually it's different for different muscle thickness. So it's around
Approximately
more than 5, 4.5 and 5 we say.
more than 4. Okay. Then what else you look for? You look for activity and whether it is diagnosis, radiological diagnosis is of a TED, then you look for the activity, then you look for
We see if there is an crowding at the apex, so that if there is an compression over the nerve or not.
what are the ways to look for that? Notice the Barrett's index. There are two ways to look for it. One is the Barrett's index. Anybody can say?
It's the vertical muscle index. I think the
Can be
vertical
vertical
width
or
of
horizontal, mostly vertical.
superior and inferior rectus divided by the height of the orbit at that point. So
Yeah. So it's more than 50%, then it is called that. Then the other way is to look for the effacement of fat around the optic nerve. So you can see in this figure, in the last one, no? Usually around the optic nerve, you'll see fat. Okay. So if there's effacement of fat for more than 180 degree or more than two quadrants, you can say that it is crowded or there is compression. Okay. So what are the investigations? One is MRI orbit. Then what else? Yeah, fields you have to do. VEP not in all cases, but it's good to do VEP in cases. Then diplopia charting. So these are the basic things that you have to do in any patient. Okay. Yeah.
Thyroid profile is normal in this patient, and diplopia charting, it shows uncrossed diplopia with LR by images noted in all left gazes and right eye suppression in all gazes except left gazes.
Okay. One very common question most patients will ask. So my thyroid is normal. Why do I still have eye disease? Why? Okay. So now patient is hyperthyroid, is now become euthyroid and still has thyroid eye disease. Why? So it's independent of each other. It's not that if this becomes normal, the eye disease will become normal. So many times the patient will say, my thyroid is under control, and also will the lid retraction, inflammation, and all subside with the thyroid control? Not really. That does not have much of. It can be independent of each other.
Fields of this patient of right eye shows constricted fields and left eye shows the inferior depressed points, and VP of this patient shows the delayed in latency in both eyes on flash VEP, and there is also decrease in the amplitude in flash VMP. In pattern VEP in right eye shows the decrease in delay in latency and decrease in amplitude. Left eye in pattern VEP shows the normal latency and decrease in the amplitude. As already discussed, MRI of this patient shows the tendons pairing enlarged extraocular muscles and hyperintensity T2 hyperintensity signals in the muscle, and the apical crowding due to the bilaterally enlarged EOM, resulting in the compression of the optic nerve, and there is the increase in the thickness of the inferior rectus, medial rectus, and the lateral rectus in both eyes.
So crowding is different from compression. Compression means there's no space at all. Crowding means there is some fat, but it is like it's impending compression. So in case of compressive optic neuropathy, you have to, it is like needs an emergency. In crowding, not all patients will require IVMP 1 gram. We do a VEP and then see, because most of them will have good vision 6/6.
So diagnosis is the active sight-threatening thyroid eye disease, both clinically and radiologically. And management, this patient is managed with the IVMP 1 gram per day for 3 days, followed by the medial wall decompression, followed by the IVMP 500 milligram weekly for 6 weeks, along with radiotherapy. This is the pre-op picture, and post-op, the vision is 6/9 both eyes, and color vision is 21/21 both eyes. And Hertels is with base 120 mm in right eye, 19 mm in left eye, and OU extraocular movements were almost full.
So the IVMP was given for 3 doses, and why was medial decompression done?
After IVM,
What was the vision after the IVMP for 3 doses?
improved, ma'am.
It improved by just one line, I think, from 636 to like probably 624 or so. So it did not improve well, and it was like a chronic case. So we did a medial wall. So it's medial floor or lateral. So why only medial was done? Why can't we do lateral wall? And why did we not combine with the lateral wall? How much does proptosis decrease for each wall? 2 mm. For each wall, it is 2 millimeters, is what they say. Along with this, you can also do fat decompression. So that is fat decompression and bone decompression. Those are two things. So more for cosmesis, we do lateral and medial wall together. This was an emergency, only medial wall, which was done via an endoscopic route. This was an endoscopic decompression. Why? So for that, you should tell me what are the approaches of orbit for decompressions. Yes, trans or the transconjunctival for the medial wall will be transcaruncular. Okay, medial wall you can do. Okay, then inferior will be transconjunctival you can do. Laterally it will be via the lid crease approach. So there are so many ways to do decompression: transcutaneous, transconjunctival. Now everything is done through transconjunctival mostly, or through the lid crease. But medially, before they used to do by link incision. Inferiorly also you can do just subciliary incisions or a subtarsal incision, but those are all nobody does right now. So medial wall decompressions can be done through transcaruncular. So why did we not do that? Because it's already an inflamed orbit. Through the orbit, the inflammation is a lot. So, but when we do through the nose, there's not much of inflammation there. So the surgical success rate is better, and it is always the medial wall which has to be done for a DON, for a dysthyroid optic neuropathy. You have to go posteriorly and then decompress the orbit close to the optic nerve. Okay, so medial wall is what is the most important wall to be done for a dysthyroid optic neuropathy. If you go and do a lateral wall, it will not be of any use. That is more for cosmetic. Okay.
Now let's have a brief discussion on the thyroid eye disease. It is also called as thyroid-associated orbitopathy, Graves' ophthalmopathy, Basedow-Graves disease. 90% of the thyroid eye disease cases are associated with hyperthyroidism, 5% with hypothyroidism, and 5% are euthyroid. Thyroid eye disease is a self-limiting, organ-specific autoinflammatory disease, in which we see the enlargement of the extraocular muscles, orbital fat, and lacrimal gland. In Graves' disease, we see the antibodies against the TSH receptors. Compared to the normal population, in Graves' disease, there is an increase in the expression of the TSH receptors on the retrobulbar tissue. When these TSH receptors get stimulated, they proliferate and they increase the production of inflammatory cytokines and increase in the production of hyaluronic acid. And there will be the few of the orbital fibroblasts, they proliferate into the mature adipocytes, and as a result of which there will be the inflammation of the extraocular muscles, pleomorphic cellular inflammation, and osmotic imbibition of water, which results in the increase in the volume of the orbital contents, which may, these particularly muscles, which may swell up to 8 times the normal size, as a result of which there will be the increase in the intraorbital pressure and in the optic nerve compression. All these changes are seen in the active or inflammatory stage. In the inactive or the fibrotic stage, we see the degeneration of the muscle fibers, which results in fibrosis, as a result of which it develops restrictive myopathy and diplopia.
What is the other autoimmune condition which usually occurs with thyroid eye disease?
Myasthenia can
Yeah, myasthenia. So what will they present with?
ptosis.
Yeah, so in patients who have ptosis in thyroid eye disease, you should always think about myasthenia. It is very important to pick it up. Okay.
Rundle's curve, it depicts the natural history of thyroid eye disease. It has thyroid eye disease has the active phase or progressive phase, which is followed by the quiescent or the stable phase. In active phase, which lasts for 6 to 24 months, it is characterized by the progressive proptosis, and the clinical activity score is more than 3. On MRI imaging, it shows the T2 hypertensive signal, and there will be the unstable squint and diplopia, and sight-threatening condition can be seen. And in quiescent stage, it has fibrosis, stable for proptosis, and clinical activity score is less than 3. And MRI, it shows the T2 hypointense signal, and there is persistent squint or diplopia. It can also show the sight-threatening clinical feature. Risk factors for the thyroid eye disease, it has modifiable and non-modifiable risk factors. Among non-modifiable risk factors, race, Caucasians has greater risk for developing the thyroid eye disease compared to the Asians, and positive familial history and age. With increase in age, usually it is common between 3 to 5 decade of life. With increase in age, there is a chance of increase in severity of the thyroid eye disease. And positive family history and the presence of the thyroid dysfunction, and presence of anti-thyroid peroxidase antibodies. And modifiable risk factors are cigarette smoking.
How many times is the risk of increased thyroid eye disease?
With cigarette smoking, 7.7 times more compared to normal population. And selenium deficiency, usually it is seen that Graves' disease patients were associated with selenium deficiency, are associated with the increase in the severity of the thyroid eye disease. And high cholesterol and life stressors are also associated with the risk factors for the thyroid eye disease. And the prognostic factors are
What is the difference between activity and staging? Activity in thyroid eye disease and stage of thyroid eye disease. Are they the same or it's different?
It's different.
Yes, the staging is the Yugovo classification, which is based on mild, moderate, severe. That doesn't have activity inside in that. Activity is basically inactive and active stage. So you'll say a stage also, you'll say the phase also. So both you'll have to say. Okay. So the staging will be mild, moderate, severe. So it depends on how what you'll do, what sort of decompression you'll do, what sort of lid surgeries you'll do, all that. Depending on the activity, will be the treatment with anti-inflammatory agents like steroids or immunosuppressants. Next slide.
Prognostic factors. Good prognostic factors are engaged Asians, females, and bad prognostic factors are the old age, Caucasians, smokers, diabetes, and stress. As already discussed, clinical features of thyroid eye disease are presence with lid signs, soft tissue involvement, restricted extraocular motility, proptosis, and the exposure keratopathy. These are the lid signs we see in the thyroid.
These lid signs you should know. I think everybody has the list of it. Some of them will be asked in exams. I mean, like when they ask you the lid sign, you should be able to say at least 6 or 7 at one shot.
Thyroid eye disease presents with various signs and symptoms. So various classifications were given to classify thyroid eye disease. no specs classification, modified no specs classification, clinical activity score, modified clinical activity score, UGO classification, and visa classification. Of all these, UGO and visa classifications are currently we are using.
Which
Clinical
are we using here?
visa classification.
What does VISA stand for?
Vision, inflammatory, strabismus, appearance. Clinical activity score and inflammatory clinical activity score of inflammatory index of the visa, it represents the clinical activity of the disease, whereas UGOGO classification, it uh, describes the severity of the disease. UGOGO severity scale, it's classified into mild, moderate to severe, and sight-threatening. If the patient has mild lid retraction less than 2 mm, minimum proptosis less than 3 mm, mild soft tissue involvement, no intermittent diplopia, or the corneal involvement which is responding to lubricants is classified as the mild. Moderate to severe, in this when this lid retraction is more than 2 mm, proptosis is more than 7 mm, and moderate to severe soft tissue involvement, inconstant or constant diplopia, they are classified as the moderate to severe. In the sight threatening, when the patient has distorted optic neuropathy or the corneal melt, is the sight threatening. No specs classification.
This is obsolete, but you should know what does no spec stand for. Okay.
Clinical activity score, it was first described by the Mortis and colleagues. It attempts to identify the patients with active disease who are likely to respond to medical therapy. Specificity is 86% and sensitivity is 55%. Clinical activity score, in this we look for the 7 clinical features, each given 1 point. In initial visit, we have to see whether there is any pain in primary gaze, pain with ocular movement, eyelid swelling and eyelid erythema, conjunctival injection, chemosis, inflammation of the caruncle. If the clinical activity score is more than 3, it denotes active disease. If the follow-up visit, if it is less than 3 months, if there is an increase in the proptosis more than 2 mm compared to the previous visit, and there is worsening of diplopia or decrease in visual acuity equivalent to 1 Snellen line, in a follow-up visit, we take into 10 points. Of this, if it is more than 3, it represents it's an active disease.
More than 4, no? If it is 10 points, the
It's
first
4,
visit is
4,
3.
4. It is more than 4.
Yes.
As already discussed, the investigations which are done in thyroid eye disease are the visual acuity, color vision, visual fields, VEP, lab investigation like TFT, anti-TPU, anti-thyroglobulin imaging.
Yeah. So the management basically depends on the stage, the
Staging.
activity, and the severity of the disease. Okay. Yeah.
Primary goal in the active phase is to preserve the visual functions and prevent complications and sequelae. In a, as classified into previously, we have discussed mild, moderate to severe, and sight threatening. In mild case, we treat with lubricants, antioxidants, home vision monitoring, and behavioral changes like quit smoking, head and elevation, cold compress. And moderate to severe, we give the pulse IVMP, 500 milligrams weekly for 6 doses, followed
So
by
in an active TD, which is moderate to severe on clinical and radiological activity, whatever, so we give IVMP 500 milligrams that everybody is aware of. No, that's what we follow here. 500 milligrams weekly for 6
6
doses. Then we reassess the patient, and if there's good response, then we don't give any more. But if there is a partial response, so you need to give some more, then we give 250 for 6 doses. Now, usually we give radiation. For whom do we give radiation?
non-steroid.
So radiation is usually we recommend in all patients who are more than 40 years of age, and if there's significant radiological activity, we do give radiation. Why do we give radiation along with IVMP? Because it decreases the relapse and the recurrence, and it causes prolonged uh, the inflammation gets subsided for a prolonged period of time. So it should also be always be given along with IVMP, like in any other situation. So we give the IVMP, then radiation is given. How much of radiation will be given?
20
20 days. So how is it given?
in 10 doses.
In 10 doses. 10 fractions, you say, not doses. So 2 gray per day we give. So then we give it along with the IVMP, under cover of IVMP. You should not start radiation and then give IVMP. Okay. So that is one thing. So that is the treatment of basic treatment that we follow here. Okay, and when can we not give radiation? What are the contraindications?
Engage.
Age less than 35. Why? Yeah, it can cause
Because
secondary malignancies like osteosarcoma and all that. So we should not give that. Then severe diabetic
diabetic
retinopathy and all
retinopathy.
also we can't give. So in patients who are not, are all patients having fit for steroids? Everybody will get fitness for IVMP. Some patients will not get fitness. No, so what do you do for them? So immunomodulators we can give. Okay, so what are the most common immunomodulators that we use? One is rituximab and mycophenolate. So rituximab is very costly, but then it has given good results, and mycophenolate also we can give. What is the latest immunomodulating agent which is not very much available in India? Yeah. Some, okay. You'll tell me later then. Okay, what is the follows after the T? Okay. So that is important. So you should say medical treatment and surgical treatment. Okay. So and this is per se, you next decompression you're telling. Hmm. Okay. Next slide. So I think we already discussed a little bit about this, and this is important. Decompression. No, for each wall it's about 2 mm with fat, and usually when we do fat decompression, we'll do along with the bone decompression. Okay. Next. So these are the approaches to the decompression. That is clear, right? Yeah. So in the medial wall decompression, what are the bones that are removed?
Segments of ethmoid bone and orbital extends into the ethmoid sinus.
What are the bones of the medial wall?
Frontal pulse of maxilla, lacrimal, ethmoidal, and lesser wing of sphenoid.
Lesser wing of sphenoid.
Yes, ma'am.
The body of the sphenoid. No? The lesser wing forms the roof of the orbit. You have put the diagram now. Yeah. Then lateral wall. What is the lateral wall formed by and why do you decompress?
Lateral worm is formed by greater wing of sphenoid zygomatic.
Okay, so then what will you, this is called as deep lateral decompression. In the past, they just used to outfracture the rim, which is of not much use. This is called a deep lateral decompression. Okay, is it okay? Yeah, tell.
Balanced decompression in which medial wall and lateral wall is both are decompressed. It is a better muscle balance and it decrease in the complications.
What is balanced decompression?
Both medial
Both
and
medial and
lateral.
lateral. It is not medial and floor. Okay, when you combine that, that becomes unbalanced decompression. So this is more for cosmesis. What is the advantage? Because in
Yes,
the
ma'am.
past they used to do more of floor decompressions. In those cases, you used to get squints and strabismus post-operatively. So medial wall and lateral wall does not cause much of a strabismus post-operatively. So it causes good decrease in proptosis. Complications are lesser in terms of strabismus.
The sequence of the surgeries which can be done in fibrotic or the quiescent phase of the thyroid eye disease are first osmotic decompression, followed by the strabismus surgery, followed by the eyelid surgery.
So that is very important. Everyone will ask in exam what is the sequence of surgery. Not essentially cosmetic, but it's decompression, then squint surgery, then lid surgery. In strabismus surgery, vertical muscles or horizontal muscle is important. Yeah, doesn't matter so much for the horizontal muscle. Why? What is pseudotosis?
Pseudotosis, when there is
What are the causes of pseudotosis?
unilateral high myopia or
Unilateral contralateral retraction, you're saying. Okay.
contralateral enophthalmus, unilateral.
Contralateral enophthalmos. You're saying causes of lid retraction, huh? Pseudotosis. Yeah, Pranav, what are the causes of pseudotosis? So, in terms of strabismus, what tropia? Hyper, hypertropia or hypotropia. When the eye goes up, the lid comes down. Huh? Usually, when does the lid follow the globe? When you look down, no. So, it is in hypotropia. What is mono elevation deficit? When elevation is not there, eye globe will be in hypotropic positions. That will be causing a ptosis. Okay. That mistake you should not make. What are the causes of that hypotropia? Most in congenital, you have monoelevation deficit. Then third nerve palsies, you have ptosis, no? Elevation deficit with hypotropia. That is why the importance of strabismus surgery comes before any sort of lid surgery. So we sometimes combine decompression with lid surgery, but we never do the strabismus part. Strabismus has to be very carefully done. Okay. So this is just an overview as to what are all the management. Broadly, you should know what is the severity, what does activity mean, what does severity mean, what are the grades, what are the options of surgical, medical management. Okay, so you have that full article in EOFTA, so you can read from there. Lid retraction, just yeah.
For the correction of upper eyelid retraction, surgeries can be done at molar muscle resection or excision, levator muscle resection, martial myotomy of levator, eyelid spacer gap. For lower lid retraction corrections, spacer graft, which can be used at tarsal plate, hard palate graft, sclera, and dermal collagen, or the lower lid recession surgery.
So when we do a decompression itself, some of the lid retraction will decrease. Then we do the lid retraction surgeries. So nowadays we are doing a full thickness blepharotomy of the upper lid. That video is okay, it's okay. So the graded full thickness blepharotomy is there. So to bring the upper lid down. Okay, for the lower lid, we most commonly do a lower lid retractor release. Okay, yeah. And tarsorrhaphy is something that everybody should know. Okay. Thank you. Thank you, sir.